Hello class, here we are again for the continuation of our lecture in nursing pharmacology. This time, we are going to discuss all about drug action. So this talks about what drugs do or how the absorption of drugs happen inside our body and its effects as well. So we start out with the three phases. We have the pharmaceutic, pharmacokinetic, and pharmacodynamic phases of drug action. We'll start with the first one. The pharmaceutic phase is also known as the dissolution. In the GI tract, most especially if drug is taken in orally, drugs need to be in solution in order for it to be absorbed. So once the oral drug enters the GI tract, it disintegrates. It undergoes disintegration. After it disintegrates, just check this illustration, it goes into dissolution wherein it proceeds to be in its liquid form. The excipients, which are the filler and inert substances, they are not the active substances of the drugs. They are just going to go through the GI tract and to be excreted out of the system. The important thing here is that the active forms of the drugs are the ones in the solute, or the ones that are being dissolved. In the pharmacokinetic phase, this is the study on how the body acts on the drug. The first phase, or the first stage of pharmacokinetics, is absorption. Once a drug has been absorbed, that's the major job of our GI, most especially if the route of administration is the oral route. The drug is going to be absorbed through the intestines and it's going to be distributed by the cardiovascular system. It's going to be carried by our blood. And once the drug is distributed to its site of action, or before rather, it is distributed to its site of action, sometimes the drug undergoes metabolism. If you will encounter that term later on, known as the first class effect. Metabolism, or also known as biotransformation, will occur. And the last stage of the pharmacokinetic phase would be excretion. And the major organ for excretion would be our kidneys. There are also other routes of excretion for the drug, which can be excreted through our saliva, through our breath, through sweat, through our feces. But the major organ for excretion would be our kidneys. So here in the absorption phase, this is the movement of the drug particles from our GI tract to the body fluids by, it can either be through passive absorption, which is a major process through which drugs are absorbed into our body. And this is the same as that of diffusion, wherein if there is a greater concentration of a drug on one side of a cell membrane, the drug will move through that membrane from an area of higher to lower concentration. And this does not need any cellular energy in the form of adenosine triphosphate, or ATP. I'm sure you've learned about ATP before in biochemistry and anatomy and physiology. Another way of how drugs are absorbed would be through active absorption, or pinocytosis. This is a process that now uses energy. This is in the form of adenosine triphosphate, or ATP, to actively move a molecule, which is our drug, across the cell membrane. So this molecule may be large, and it is often a very important process in the drug excretion of, or in the kidneys. So this is how passive transport occurs. So movement of drug molecules from an area of higher concentration, which is outside the cell wall or cell membrane, to an area of low concentration. While active transport, as you can see here, it uses up ATP in order for the molecules of the drug to enter the cell. Now for the distribution, this is the process by which the drug becomes available to body fluids and body tissues. Like what I've said earlier, the blood is the vehicle for the drugs that are taken in by the patient. It also is talking about the drug's affinity to the tissue, to the site of action, where the drug is intended for, and as well its protein binding effect. Because there is most drugs, some of them, they bind to albumin inside our blood. So that's one factor that we need to take into consideration as well in the distribution. Let's talk more about protein binding effect. Here, as drugs there are distributed in the plasma, many are bound to varying degree with protein. They can be highly protein bound drugs, moderately high, or moderately high, or moderately protein bound drugs, or low protein bound drugs. So this portion of the drug that is bound to protein is inactive, so it won't do its function because it is not available to our receptor sites of the cells. And the portion that remains unbound, which is free, the one that is free floating in the plasma of our blood, this is the active drug. So if the drug is bound to protein, it becomes inactive. So only the free drugs that are active, these are the ones that can cause a pharmacologic response to the patient. But this one, we need to take this into consideration as well, because if the case of the patient is malnourished, they have lesser albumin in the blood, average or doses of drugs can be toxic to them because of this factor of the protein binding effect. There's lesser protein for the drug to bind to, therefore more free drugs will float freely in the plasma, and if it's too high, it can cause a toxic effect to the patient. Next, we talk about the blood-brain barrier. So here in the blood-brain barrier, this is a semi-permeable membrane in our central nervous system that protects the brain from foreign substances. So this one, it also is a protective system of cellular activity that keeps the brain safe from many things. So for example, foreign invaders, microorganisms, bacteria, viruses, protozoans, and so on, certain poisons that can enter our body, drugs as well. So the blood-brain barrier is, or it serves as a protection from these foreign substances that can cause harm to our central nervous system. And highly lipid soluble drugs are the ones that are able to cross the BBB, or the blood-brain barrier. Also, during pregnancy, both lipid soluble and lipid insoluble drugs are able to cross the placental barrier, which can affect the mother and the fetus. That's why obstetricians, they should be very, very careful in prescribing medications for pregnant mothers, because some of them can cause harm to the growing fetus. They can be teratogenic for the growing fetus. Another would be the risk-benefit ratio. This also should be considered before drugs are given during pregnancy, because if the risks are higher than its benefits, then, like what I've discussed during our previous topic, for the development of the drug, during the different phases, if the risks are higher than its benefits, then they are going to pull out that drug that is being developed. Also, we need to take into consideration mothers who are breastfeeding or lactating, because during lactation, there are certain drugs that can be secreted into the breast milk, and these drugs, once once they are secreted into the breast milk, it can cause harm to the infant. So, obstetricians or uh, pediatricians can take this into consideration as well. Now we go to metabolism or biotransformation, the pharmacokinetic, which is one of the pharmacokinetic phase. So once drugs are absorbed in the intestines, they are further absorbed via the portal system. These are the veins that are draining the intestines, both the small and large, with these with blood. These blood, they are nutrient-rich blood that will be delivered later on once it passes through the liver and to the vena cava to the different cells or tissues of the body, including it includes the drugs that patients may have taken in orally. So they are absorbed into the portal system, which is a group of veins that drains the intestines with blood. Once these veins drain the blood or drain blood from our intestines, they go now through the liver, which is the most important site of drug metabolism. So everything that is absorbed through the GI tract now first enters the liver to detoxify many chemicals. So this the one that the term that I've mentioned earlier, which is the first class effect, now happens here inside the liver. So some molecules of the drugs may be deactivated by the liver. That's why the dosage should be taken into consideration as well. And once drugs are now flowing freely into the bloodstream, some of them can be or can bind to the plasma protein that I've mentioned earlier in the circulation. And these freely floating drugs, which are the active form, will be the one to help treat the patient, since these free floating drugs are the ones that have a pharmacologic effect on the patient's body. Now we talk about the half-life. We're not talking about the game here. We're talking about the drug half-life, and this refers to the time it takes for the amount of the drug in the body to decrease into 1/2 of the peak level it has previously achieved. So it means, for example, a patient has taken in 500 milligrams of drug. It depends on the half-life of the drug. Each drug has a unique half-life, and it determines the appropriate timing for drug dose or the duration of drug's effect on the body. So there are certain drugs that are given, let's say, for example, every 4 hours, every 8 hours, every 12 hours, because by that time, probably after 8 or 12 hours, the drug's dosage has been reduced into half. That's why this is also taken into consideration by pharmacists, doctors, and so on, in order to give the proper timing, the appropriate timing for the drug dose for the patient. Example, the patient takes 20 milligram of a drug with a half-life of 2 hours. That 20 milligram will become 10 milligram after 2 hours. So that's what happens. If the patient didn't take another dose after 2 hours, that 10 milligram will become 5 milligram after 2 hours more, and it will be further reduced into half. 2.5 milligram will remain in 2 hours, 2 more hours. So that's how half-life works. So this should be taken into consideration when they are going to give or assign the appropriate time for the drug dosage. There are certain antibiotics that are given every 8 hours. every 6 hours, because the half-life of that antibiotic was taken into consideration. Other factors to consider determining the half-life of the drug is its absorption rate and its ability to be distributed to the body tissues. Also, the biotransformation. Sometimes if the patient is suffering from either a liver or kidney disease, we are also going to take excretion into consideration here. The drug is going to be, or the dosage of the drug is going to be adjusted by the patient's physician according to the disease that the patient may have. Like for example, if the patient has hepatitis, or the patient has liver cirrhosis, or the patient has, let's say, chronic renal failure, they need to take the drug dosage into consideration when prescribing drugs to patients. And the final phase of the pharmacokinetic would be excretion, which is the removal of a drug from our body. Routes can include the skin, through sweat, through our salivary glands, so drugs can remain there, through the lungs, through bile and feces, which I've mentioned earlier. And the major organ for the excretion of the drugs that we may have taken in would be our kidneys. They play a very important role here. So in order to check if our kidneys are functioning normally, these tests are going to be done in order for the doctor to determine our renal function. And the following tests, both of these, creatinine clearance and BUN, blood urea and nitrogen, are going to be tested to determine whether the patient has a problem or a kidney problem or not. The GFR, or the glomerular filtration rate, may be the best test, but this is somehow expensive. So the doctor, so if the patient is suspected to have kidney failure, they are going to do tests like this in order to properly give the proper amount or the proper dosage of the drug to the patient who may have a kidney disease. Now we go to pharmacodynamics. This is the science dealing with interactions between the chemical components of living systems. So that's our biochemistry, the biochemistry of the human body, and foreign chemicals, which includes drugs that will enter our bodily systems. That's how pharmacodynamics is all about. And these drugs that can enter our body, they usually work in one or four ways. There are four functions of a drug. The first one is to replace or act as substitutes for missing chemicals. Let's say, for example, a patient is suffering from diabetes mellitus type 1. And for diabetes mellitus type 1, we all know that their pancreas is no longer functional. They no longer produce insulin, which is a hormone needed to maintain the blood glucose levels. In order to replace the missing insulin that the pancreas is not producing in a patient who has diabetes mellitus type 1, we are going to administer or teach the patient to do self-administration of insulin. So this is a great example. Another function of a drug is to increase or stimulate certain cellular activities. Let's say, for example, the patient has entered cardiac arrest, brought about by myocardial infarction. For example, there are certain drugs that can restart the heart of the body. So it can stimulate the cellular muscles of the heart, the cardiac muscles of the heart, such as epinephrine. That's why if you can observe Hospitals, if the patient has undergone cardiac arrest, they are going to try to defibrillate the patient first. They're going to introduce electric currents. If defibrillation is not successful, they are going to administer drugs that will help stimulate the heart to pump again, such as epinephrine. Other agonistic drugs, I'll explain how agonists and antagonists act later on. They Agonists, they stimulate certain cellular activities. So they either increase the heart rate or they increase the patient's GI movements for patients who are experiencing dyspepsia and so on. So these are examples of drugs that increase or stimulate certain cellular activities. If there are drugs that increase or stimulate cells, there are also drugs that will depress or slow certain cellular activities. Let's say, for example, a patient is suffering from hypertension, high blood pressure. The patient may be given antihypertensives in order to lower down the patient's high blood pressure. Another example, if the patient's heart rate is increased because of cardiac arrhythmias or because of heart failure, the patient's heart rate can be decreased if given, let's say, for example, digoxin, which is a drug for heart failure. It has a negative chronotropic effect on the drug. I'll explain more about digoxin later on once we go into drugs that act on the cardiovascular system. So these are examples of drugs that will help slow or depress certain cellular activities. And lastly, there are certain drugs that will interfere with the functioning of foreign cells, such as an invading microorganism or neoplasms. These are known as chemotherapeutic agents. Like what I've mentioned before, chemotherapeutic agents is not exclusive for the treatment of cancer alone. This is for the treatment of invading microorganisms or cancer cells, which are also known as neoplasms. So we have a lot of drugs that will interfere with invading microorganisms, such as we have antibiotics. They help treat bacterial infection. Also antivirals, which help treat viral infections. Antifungals. If you have a skin fungal infection, this will help get rid of your fungal infection. Antiprotozoals, if you have a protozoal infection, such as, let's say, amoebiasis, can be given an antiprotozoal. We also have, if you have parasites in your body, you may be given anthelmintics. And lastly, antineoplastics if a patient is suffering from a cancer. Now we talk about the receptor sites. These are the sites where drug molecules bind to in order for it to be absorbed into the body. So this refers to specific areas on the cell at which many drugs are thought to act on our cell membranes, and they act the model, the lock and key model. The lock is the cell membrane, and the key, which is an enzyme. The lock and key theory is the best theory that can illustrate this. We have agonist interaction with the receptor sites, wherein these receptor sites, if they are given agonistic drugs, when we say agonist, they further increase the function of the cells. Let's say, for example, it will increase the heart rate, it will increase the patient's blood pressure, and so on. And we have two types of antagonism. We have competitive antagonism. There are some drugs that act or react with the receptor sites to block normal stimulation, therefore producing no effect. So these drugs, the molecules of the drug will react with the receptor sites wherein they are going to block certain enzymes or certain substances that will try to enter the cell, which will stimulate the cell to do its activity. So there are drugs that can do that. Another is non-competitive antagonism, where other drugs react with specific receptor sites on the cell, and by reacting there, prevent the reaction of another chemical with a different receptor site on the cell. In non-competitive antagonism, there are drugs that will react to certain or specific receptor sites. These specific receptor sites, once these drugs bind there, the other receptor sites that are responsible, let's say, for example, for the stimulation of the cell's functioning, will cause the blockage of these substances to enter the cell membrane. So that's non-competitive antagonism. So those are the two things that a drug or drugs do with the cell membrane. They can cause an agonistic interaction with our cell membrane or an antagonistic interaction. We'll discuss more of those with drugs that are known to be agonists and antagonists. And there is also this term we know we have here known as selective toxicity. This refers to the ability of a drug to attack only those systems found in foreign cells. So they attack. They select a certain system that they are going to be toxic with. That's why it's known as selective toxicity. Now we go to the factors influencing drug effects. First would be the weight. If you are as fat as this guy, if you're overweight or obese, the doctor may need to increase your drug dosage. Or if you're malnourished or very thin, the doctor may decrease your drug dosage. So weight can play an important factor in the prescription of the drug. Age as well. As we all well know, as for children, since the drug that is being marketed is intended for adults, for children, usually the doctor is going to base this from the child's age or the child's weight in order to compute for the drug dosage appropriate for a child patient. I'll teach you those things later on as we proceed with drug computation. Or if a person grows older, as we all well know, most of their bodily functioning decreases. So the doctor should take the age of an adult patient as well, most especially if we are dealing with elderly patients, because elderly patients may need to have a lower dosage of a drug for it to be effective. Gender, there are certain drugs that are specific to the sex of the patient. Let's say, for example, birth control pills can only be given, of course, to females. They have a different reaction to males. It can cause gynecomastia if birth control pills are given to males. And of course, let's say, for example, Viagra, they can only be given to males and not to females, because the side of action of Viagra would be the penis. So there are certain drugs that are gender specific or sex specific. Another would be physiologic factors. So if the patient, one of the physiologic instances that the patient can have would be pregnancy, which is a very normal thing to happen. So for a pregnant mother, most drugs are teratogenic for them. And the obstetrician should be very, very careful in prescribing certain drugs because there are certain drugs that are contraindicated to pregnant mothers. Another would be pathological factors. So if the patient is suffering from a disease, let's say for example, liver or kidney disease, the doctor again should make adjustments with the drug dosage to prevent toxicity from happening in a patient. So this can play an important factor as well in the prescription of a drug. So they need to check first the liver enzymes, test the liver enzymes for the functioning of the patient's liver, the AST and ALT, or the tests done for the kidneys if the doctor is suspecting the patient to have kidney failure. Another would be genetic factors. There are certain drugs that can cause allergies to patients, and allergies are genetic. Um, some of my family members they can be allergic to certain foods. So we have the gene that can either cause drug or food allergies. So if a patient, for example, is allergic to a certain antibiotic, the doctor should change it to a different type of antibiotic in order for the patient to be treated for that specific infection. Another would be the patient's immunological functioning. So if the patient is immunocompromised, for example, the doctor is again going to take this into consideration. Let's say, for example, if the patient is taking in anti-neoplastic agents, because anti-neoplastic, the anti-cancer drugs, they can cause immunosuppression. Or there are certain disorders such as AIDS, they can cause immunosuppression. They should take that into consideration as well in the administration of certain drugs, because there are certain drugs that can further compromise the immune system of the patient. Let's say, for example, some anti-inflammatory drugs, they can cause immunosuppression. So the doctor is going to avoid prescribing those kind of drugs since the patient is already immunocompromised. Psychological factors as well can play a great role in drug administration, because if the patient believes that the drug is not going to work, that can play a major role in the behavior of or the interaction of the drug with the patient's body. If the patient believes that he or she is going or still going to experience pain despite being given an analgesic, then there may be a problem. So this can also be a great role in the administration of drugs, most especially for patients who are suffering from psychosomatic disorders. Environmental factors can also affect drug absorption, especially if the weather is cold, or very, very cold during winter. We don't have a winter season here in the Philippines, or the weather is extremely hot. They can play a major role in the absorption or distribution of drugs. Think about vasoconstriction and vasodilation during a hot or cold weather. So that also plays a factor in drug absorption and distribution. Drug-drug interactions. There are certain drugs that you must avoid or that you must avoid combining together because they may be toxic or they are antagonizing each other. So if these two drugs, they antagonize each other, they won't do a pharmacologic effect on the body. Or sometimes they are creating a synergistic effect. So they increase the potency of another drug. So those things can happen when taking several drugs at the same time. Let's say, for example, if a patient is taking in iron supplements for the treatment of iron deficiency anemia, iron supplements has a synergistic effect with another drug supplement, which is vitamin C. So vitamin C can increase the efficacy of iron supplements. Another would be drug-food interactions. So there are certain drugs that are that when taken in with food or beverages, it can cause a synergistic effect as well, or it can increase its potency in a patient. I have been practicing this for a very long time now. There's a certain drug that can be very effective when taken in with a certain beverage. For example, if I am having a massive headache or a headache because of the weather, because of the changing weather, like what we are having today, together with paracetamol, which is the common drug for headaches, I am going to take it with coffee. And coffee will increase the potency of paracetamol within 15 minutes. Sometimes it takes 15 minutes. My headache is going to be, or is going to disappear. So that's how drug-food interaction works. If you can observe certain medications in drugstores, there are already paracetamol that is combined together with caffeine, because the caffeine content of coffee will help increase the absorption of NSAIDs, or non-steroidal anti-inflammatory drugs such as paracetamol, into the bloodstream, making it more effective. So the pain is going to disappear after a few minutes. And based on my experience, sometimes it disappears around 15 to 30 minutes. So that's a positive drug-food interaction. We also have a negative drug-food interaction, wherein, let's take, for example, monoamine oxidase inhibitors. These group of drugs are being used to treat depression. They are under antidepressants. Now, patient teaching is very important in the administration of monoamine oxidase inhibitors. You'll learn more about that later on. They're also known as MAOIs. They're short, or in short, they're called as MAOIs. And MAOIs, you are going to teach the patient to avoid certain foods together with the administration of MAOIs. Why? Monoamine oxidase inhibitor, once mixed with foods that are rich in tyramine. I'll give you a great example of food that is high in tyramine: pizza. There are certain meats in pizza that is high in tyramine, even the cheese that is being used. So if this antidepressant MAOI is taken in together with that food, it has a negative effect on the patient's body, which can cause a hypertensive crisis. The blood pressure can shoot up as high as 200 over 100 millimeter mercury. So that is very, very dangerous. So we need to take this into consideration as well, because it is risky for certain drugs to be taken in by patients when eating certain foods, such as that example that I've given you. So that is all about drug-food interaction. So that's it for our lecture today. If you have any questions about the lecture that I have done today, you can message me anytime. And again, class, thank you very much for attending today's lecture. Please wait for the next video that I'm going to be uploading regarding the toxic effect of drugs and the nursing process regarding pharmacology. Again, thank you, class, and have a great day.